We continue now in our program, and we will have our last speaker, and I'm also happy to present you Louis Appleby. I hope I pronounce it correctly. I also know his work quite well. I have cited him quite often previously. He leads the National Suicide Prevention Strategy for England, and he's a professor of psychiatry at the University of Manchester, where he leads the Center of Mental Health and Safety, investigating suicide, self-harm, and other areas of risk. And he also is director of the National Confidential Inquiry into Suicide and Safety in Mental Health, a UK-wide study that aims to improve the safety of mental health care. So very much expertise in that. And Louis will give us a presentation of England is an increase in suicide deaths to be expected post COVID-19. And so please, Louis, take the floor if you are online, which I think you are. Can anybody assist?
Are you hearing me?
We're hearing you. Oh, yes, we're hearing you.
Right. I can sort of see the room now, so it looks like I might be there. Thank you very much for inviting me. Hope everyone is well. I'm going to talk about our experience in England of suicide prevention during the pandemic. I'm going to talk about some of the England figures, but also I want to talk about where it takes us into the next phase of the pandemic, which for many countries is starting around about now as we move into a time when many people are vaccinated and society is trying to open up. What does the experience tell us about this next phase? I'm going to present quite a lot of statistics and graphs. I hope that's your interest. We work a lot with families of people who've died by suicide, and they always ask us to say at the beginning of our talks that these graphs represent real lives, real people lost, real families devastated. I'm going to start, see if I can
Are you
share the screen
already?
now. I'm just trying to do that now. Can you see my screen?
Yeah, no, you're sharing now. Thank you.
Great. Okay. So, pleasure to be here. So, the England experience. The first thing I should say is that suicide prevention, the challenge that we have faced in the last 18 months, did not actually start with COVID. Suicide was already rising in a number of countries, including in England. And the future task is a combination of what COVID has done to mental health, but also the problems that we were facing before the pandemic began. It's a combination of those two adversities. You've already seen a version of this slide already. This is a paper that a number of academics worldwide published at the very beginning of the pandemic in April 2020. I was an author, Lars was an author. I think it's the only time we've been co-authors. And it was an immediate response to the concern that many people had that the pandemic would raise the suicide rate. It wasn't difficult to see why people were worried. The pandemic brought a fear of illness. For some, it brought isolation. For some, there was a loss of support, loss of routine. For some, a loss of the access to care that they had relied on, and for many, an economic threat. So it wasn't difficult to see why suicide might go up, but in the paper we argued that we were not starting with a blank sheet. We already knew from a number of national strategies how to approach the problem of suicide prevention, and we needed to adapt our existing knowledge to this new situation. I should say that The England strategy, which I drew up in 2002, drew heavily on the strategy from Finland. So I don't think I've ever thanked you. So thank you very much for your influence.
You're welcome.
In the paper, we said that we needed a combination of mental health and targeted interventions towards people who might be at risk, and also, let me just get one of these, a laser pointer. So that a number of interventions targeted at groups at risk, and a number of interventions which were universal to society as a whole. So a classic combination of a public health approach. So that was our setting out of the Suicide Prevention Challenge. What happened next? Well, over the course of the next few months in England, a great deal of alarm was raised about the possibility that suicide may already have risen. In fact, a number of people not only predicted but claimed that suicide rates had gone up. And those claims came from people who were well-meaning, well-informed, and drawing on partial data. So from charities, sometimes from professionals, but they also came from people who had a political interest in arguing that lockdown was harmful. So here's a few examples. I just want to draw your attention to one of them. That's this one here, a very widely shared tweet which claimed that the suicide rate had risen 200%, whatever that means, since lockdown. And that we were able to take down that claim, persuaded the author of the tweet to remove it, but not until it had been shared 31,000 times. So the message that suicide rates were spiraling out of control was out there in society long before any actual figures. And in this paper, some colleagues of mine in Oxford, Keith Horton was the leader, argued that alarm in itself would be harmful to people's mental health and to risk. But as we reached towards the end of the year, we began to get actual data. Now, we monitor self-harm in England through a number of hospitals which tell us about self-harm presentations to emergency departments. And one of them is in my base in Manchester. And this slide is showing the Manchester data. So this is hospital attendance. And as with many of my slides, you'll see marked the time of our first lockdown, and then restrictions start to ease. And then later in the year, we had a second lockdown. And the yellow line here is showing total numbers of presentations for self-harm in Manchester. And it followed the pattern that we found nationally, which was that initially there was a fall in presentations, and then gradually the numbers began to return to what they had been, but they never exceeded the pre-COVID figures. Now, why was this happening? Well, it may be that some people responded to the crisis by focusing on COVID, as has been suggested today. It may be that certain methods were restricted. It may be that people were just as distressed, but they were keen to protect the NHS. After all, the government had a very strong message about protecting the NHS, so not attending unnecessarily. But in any case, there was no evidence of a rise. But this is hospital data. What about the community? So now we're drawing on a very interesting study by colleagues of mine at UCL, who, from the very beginning of the pandemic, conducted a national survey of well-being, which they repeated every few days, so that there is a constant recycling of people providing information about how they are feeling, about their behavior, how they're coping. And it's a big study, has 70,000 people. And this is a slide taken from that study showing people reporting recent self-harm. Now, as you'd expect, so there's a few different slides here, but this is self-harm by different age groups. So as you'd expect, younger people, people on lower income, showing people with mental health problems, all showing higher rates than the population generally. But none of these groups showed an increase in self-harm as the pandemic proceeded. So here is towards the course of the whole of 2020 and even up to the most recent figures for last month. No rise in community-based self-harm. Now, does that mean that the pandemic had no effect at all on self-harm? So this is an interesting study carried out also as part of our self-harm monitoring. This one is in Oxford, again, Keith Horton's group. Here, the question is not the rate of self-harm, but the reasons for self-harm. And now we're seeing people reporting that COVID was one of the main reasons why they felt distressed enough to self-harm. And in fact, COVID-related factors were found in almost half the people who attended hospital. So it isn't just a question of rates, it is also a question of shaping the self-harm response. Suicide, self-harm never has a single reason. COVID may have been contributing. But what about suicide itself? Well, that was much more difficult because in England, the suicide rate is monitored through the results of inquests. Coroners, who are legal officers, make their decisions about the cause of death. That's registered by the Office for National Statistics, but the whole process takes some time. The median time from death to registering a death is 166 days. Far too long for us to monitor any change in the suicide rate. So we had to set out and collect a new suicide data from a new source. Now, in many parts of England, they've begun to collect what are referred to in suicide prevention circles as real-time surveillance data, RTS. And this means collecting information on suicides as they happen. These are suspected suicides, they haven't been to inquest, and it's usually done locally to look for local patterns of suicide that may differ from the national picture. We were able to combine the local RTS into a picture of what was happening across the country. And we did that by combining the data from 10 English NHS regions. They're marked on the map there in the dark shade. And altogether, they add up to a population of 13 million people. So a quarter of the country, but obviously quite a sizable population. And the time period that we initially covered, so this is the initial publication, was the first 7 months of the pandemic during 2020. Now, what did we find? We were able to plot the suicide rate in these 10 areas by month. The data for previous years was less reliable, although we were able to make a partial comparison. So the main comparison here is the pre-lockdown months and the post-lockdown months. And during that time, we saw no change in the national suicide rate. In fact, the suicide rate after the onset of the pandemic, which is here, the national suicide rate actually fell towards the later part of the year. Certainly, we saw no significant rise during lockdown, that's here, and no significant rise in any month subsequently. Even that one there is not significantly high. So what did we conclude? We published this study initially in November, then again in April this year. We concluded that the very large rise, the escalation that many people were predicting had not happened, that in fact we could find no evidence of any rise in suicide, but that many caveats applied. First of all, this is the early pandemic. Secondly, it's overall figures. It's not broken down by demographic variables. It's quite possible that beneath these overall figures, there is variation locally or between population subgroups. After all, COVID itself has not been uniform in its effect on people. And of course, the use of RTS in this way is new. We also raised the point that has run through our understanding of the pandemic, and that is that the real threat to suicide rates will come when there is an economic downturn. So economic adversity is still the lurking threat. Now, since then, we've seen more figures published in England. So in September this year, so quite a long time after the real-time data, the Office for National Statistics published their figures. And they were able to improve on ours in a number of ways. First of all, they had the whole population. Secondly, they were able to compare to previous years. So if you look at this group of columns here, here are the 2020 figures for the first months of the pandemic, compared to the same months in previous years. Now, ONS in their report said that there was no rise, but they were being quite cautious because there was in fact a 5% fall. And then that fall was predominantly in men. It was less obvious in women. They were able to break down their figures into by age, and the most striking thing about this slide is that the year-on-year figures show the largest fall in the youngest age group, people under the age of 25, the group in whom a great deal of concern had been expressed. One other point to make, just in reference to the previous talk, the one exception to the story of a fall, certainly an absence of a rise, was women over 75. So it may be that something about older people did not receive the protection that whatever was happening to other people. Now you might say, well, okay, this is all 2020. What's happened since then? So this is our slide. This is unpublished data showing the months since we published. This is where the previous slide ends. So here's our RTS data. And despite some volatility throughout the second lockdown period in England and into the reopening in the spring, we have still seen no rise in the suicide rate. So why is it that when it is so logical that the stresses of the pandemic might raise the suicide rate, why is it that when we have plenty of evidence that people have been more distressed, that depression rates have risen in some groups at least, why are we not seeing a rise in suicidal behavior? Well, I think the first thing to say is that the two are not the same. So it doesn't logically follow that distress leads to despair, and we have to understand the difference. To give you an example, the most obvious example, women have the highest rate of depression, the higher rate of depression, men have a higher rate of suicide. The two things do not necessarily go together. But what is it about the pandemic that may have protected some people? So alongside risk, there may have been greater protection for some people. What is that protection? Well, for some, it may have been that the closer relationships, the confinement that many people had to endure led to increased vigilance, that society was more careful, more watchful, and more supportive, that we were more careful about what was happening to our family, our friends, and our neighbours. It may be that there was something broader, a wider increase in social cohesion, that something more abstract was happening, that we were trying to get through this together. It may be that there was a sense of that this was short-term, that the pressures, the stresses were something that would pass and then we would get back to normal life. And that short-term nature was helpful. And of course, there may be conventional suicide prevention reasons, like reduced access to certain suicide methods, railways, for example, which for a period of time were largely closed down. So can we learn from those possible protections and say something about suicide prevention from now as we move into the next phase? Well, so my question, I'm moving from a question now of whether the suicide rate went up, but something I think more complicated, more nuanced. Are there people in whom it went up? Okay, it didn't go up in the entire population. What about the subgroups in the population? Are there particular people who are affected? Why, when, and where? So this is an interesting study from the United States. Now, we know that the suicide rates in the States also fell in the same way that they did in the UK. But in the United States, they've seen a difference by ethnicity. And this is not national data. This is from a single US state. But it makes the point that as the pandemic proceeded, they began to see a fall in suicide rates in the white population, which did not happen in the black population. In fact, there may have been a rise in the black population. And there's some evidence that this happened in other parts of the country. Why? Well, the authors of this study suggested it was not just ethnicity, but economic vulnerability. COVID has played out its impact on the fault lines in society, and those fault lines are partly ethnic, but they are also economic. Now, the economic story is an important one to us in England because we've seen the impact of previous economic recession. So now I want you to look at this graph here, and the middle line is the national suicide rate in England for the last 20 or so years. And here you'll see that there is a point there where we had the lowest suicide rate ever in England for 150 years in around 2006. And then the suicide rate began to go up. The recession hit in 2008, and we saw a rise in suicide until about this point here, 2013-14. At its peak, this was an extra 700 deaths a year. But the most important thing is that its peak was about 5 years later. So the impact of the recession appeared to be long-term. And if there is to be an economic consequence to COVID, we can expect it to be long-term too. Now, the government in this country has actually acted quite quickly to support people who may be economically vulnerable. These two images are a reflection of some of the government actions to support people financially. But there is now, as society reopens, talk of withdrawing the supports for people in employment, for people on welfare. And the risks there are that the long-term consequence that we've seen before will not be prevented. So the long-term impact of COVID via the economy on suicide rates is one of the biggest challenges we face. People facing debt, people facing mortgage arrears and losing their homes. Now, so there are economic threats ahead. What about the issue of COVID itself? You might expect that as people are being vaccinated, there's a sense of society reopening, that the COVID stress that we feel is diminishing. And this is the same study I mentioned earlier from UCL. And in fact, the COVID stress, the number of people reporting being stressed about COVID, has diminished this year compared to previous years. But an important difference is that for some groups, it has remained higher. So a sense that in this slide, for people with a mental health problem, although there's been some reduction in COVID stress, it hasn't been as great. And now what looks like an opening up of a gap between people who are feeling less stressed and people who, with a mental health problem, are still feeling more anxious about the infection itself. A kind of vulnerability gap. The benefits of society returning to normal not being shared by those people who are on the wrong end of inequalities. Who else might be affected? Well, one of the main determinants in England of mental ill health during the pandemic has been loneliness, a very important driver of depression and anxiety, most studies have suggested. But who is more lonely? Well, this again, the UCL study has monitored loneliness throughout the pandemic. More loneliness in women, ethnic minorities, people who are less well educated, and people who are physically ill. So this group here, people whose physical health is poor and who might be expected not to benefit from the wider opportunities in society, for whom social distancing has really been a confirmation of their pre-COVID lifestyles, living solitary and distanced life. Now, there's one kind of physical ill health which we are particularly worried about, and that's so-called long COVID. Still being explored, but a very important condition. And these are two studies carried out by the Office for National Statistics on what we know about long COVID. So the first slide is telling us in people who report persistent COVID symptoms, what is the impact on their daily lives? And it's broken down by age groups. So this is children, and this is up to people who are over 70. So and the yellow and orange component of these columns is the proportion of people who say that their daily lives are impacted by their long COVID symptoms. And so the impact of long COVID on people's lives is greater in children, according to this study, and in people who are older. So if we're worried about the suicidal consequence of physical disability, of chronic physical ill health, then these are the groups who we should be most concerned about. And it's not just age. Here is another partner study in which, looking at various definitions of long COVID, ONS asked people, tried to work out the prevalence. So this color here, this sort of pale purple color, is combining all definitions of long COVID by any duration of symptoms. And you can see that the slide is showing differences between the most deprived members of the society and the least deprived. And so long COVID and its impact is stronger in people who are already most deprived. So you can see the beginning of a coherent picture about future risk. We should be worried about people who are economically vulnerable, people who are more isolated, people who with mental or physical ill health, including long COVID, and the people who are not getting the advantage, if you like, of the the return of society to something more normal. The vulnerability gap is getting wider. But what about these more abstract concepts like social cohesion? Well, this is another government-related study where how do we measure social cohesion? Where the effort to measure social cohesion was turned into a particular variable, which is how often we talk to our neighbours. So this is a study which asked people to compare how often they are in contact with their neighbours during the time between wave 1 of the pandemic and wave 2, so throughout the period of 2020. And this, by the way, is Emil Durkheim, who would be very interested to hear that we are still talking about the impact of social cohesion so many years later. He described the impact of social cohesion in 1897. So this is a kind of homage to him. And this is actually his grave in the Montparnasse Cemetery in Paris, where those stones are actually direct homage to Durkheim. But in any case, chats with neighbours. When do we speak to our neighbours? So this is what people saying that they have spoken less to their neighbours during the course of the pandemic. And the yellow and red components of these columns are the people who say they see their neighbours less. And the people who say that are young people and ethnic minorities. So you can see that despite the reassurance about suicide rates in young people in the ONS study, the concerns about young people are growing. And here is a very interesting slide from a group called NHS Benchmarking, who collects mental health service data nationally across the NHS. And it's interesting because it tells us something about the pre-COVID period. This is referrals to children and adolescent mental health care nationally. And it shows that in the period before the pandemic, there was a rise, a very sharp rise actually, in the number of people who were being referred into CAMHS services. And it goes with a rise in the suicide rate in young people in England throughout the 2010s. From around 2010 to currently, we've seen a rise. And when I say that we have to remember the pre-COVID trends, this is the kind of thing I have in mind. Suicidal behaviour, mental ill health in young people was growing. Now, the elegant thing about this slide is it then, when we reach 2020 in the COVID period, it breaks down the referrals month by month. So this is month by month. And as you can see, there's the initial drop, like the self-harm attendance. But then there was a big rise. And this rise is considerably beyond anything we saw in previous years and has continued. There's the second wave, by the way, and has continued, maybe a little bit of a drop now, but in any case, far more people being referred into CAMHS services than before. So a suggestion that young people are showing increasing potential vulnerability. And finally, for these graphs, the abstract issue of optimism. If I'm right to suggest that something about the short-term nature of the COVID crisis helped people get through it psychologically, then what do people think now about the short-term nature of the crisis that we're in? So this is a very interesting study that ONS colleagues have carried out. This is a study which has repeatedly asked the population how long they think it will be before life will return to normal. They have a number of time points. I've selected these time points. I should mention. So here is April. This is the first few weeks of the pandemic. Here is the period last year when England was opening up. We were being encouraged to go out and return to normal. Then, of course, we entered our second wave. So this is the height of the second wave, and this is the most recent picture. So this is just last month. So when will life return to normal? Right at the beginning, the majority of people said that would happen within 6 months. Quite an optimistic view. And then that has changed over time. You see that even though 18 months has passed during the course of this slide, people have begun to see the pandemic affecting us for a much longer period of time. And now the commonest answer is that it will still take more than another 12 months before life will return to normal. By far the commonest answer now. And then alongside that is this purple bar, which is people saying it will never return to normal. And initially in the pandemic, very few people thought we would never return to normal. Now, it's 1 person in every 9 believes that life will never return to normal. Now, the psychological importance of this is about this sense of optimism, about hope, about seeing the future. If we believe that the pandemic will always be with us, there is a risk of a kind of emotional weariness which will counteract the potential protection of seeing this as a crisis that we can get through together. So that long-term pessimistic view matters to mental health. So what can we conclude from the England story? Well, first of all, I should stress that the pandemic has had a significant impact on people's mental health. We have plenty of evidence that that is the case. But this has so far not translated into a rise in suicide or self-harm. The reason for that suggests that the future risks will come from economic adversity, from isolation, from mental and physical ill health, including long COVID, and that people who might be most affected include young people and mental health patients. And therefore, the most important suicide prevention measures into the future are the maintenance of economic protections, the strengthening of mental health care, responsible media coverage, just to go back to what I said about the coverage early in my talk, and positive social attitudes to each other and also to the future. And I want to end on the point that I made right at the beginning, that the other part of recovering from the pandemic is to recognize the mental health challenges that we faced before the pandemic and what was happening to suicide rates in young people, and so on. But that subject is the topic of a different lecture. Thanks very much for listening. It's just a quick word for all the people who've been doing the work that I've been quoting. This is our research team. This is how we used to look, and this is how we look now. Thanks very much for sharing.
Thank you very much for this great data and your, should I say, comprehensively conclusive speech. I think you said it all in the end in your conclusions. And unless I see any hands or questions in the chat, I'm very willing to go directly to our ending of this session. But in case there's one, okay?
Thank you, and thanks for all presentations. My name is Sanna Vesikansat. I'm working for Mieli Mental Health Finland. I just started this week, so still learning also the name. Just a comment on the ethnicity. I think this is something we haven't actually discussed so much. Not in Finland. I don't know about the other Nordics. We discussed that the COVID hit the different ethnic minorities very differently, also in Finland. But it has been very difficult discussion also here. And I think that is something, and your slides were very interesting, and something that we should be also ready to discuss, because I think the experience has been very different, looking at from different groups, where, for instance, mortality in Finland has been very low. So white Finns probably don't even know anybody who has been in the hospital or has been dying. But then looking at from different subgroup, the whole crisis could look very differently. And I think your point about the economic consequences was also very interesting. Then just another point about the young people, and a question to you, Luis. How do you see these slides about hope and what you showed us in the last slides? Now thinking of the young people, for them 1.5 years or 2 years is huge period in their lives, and I think also now when we know that there could be not even the immunizations didn't maybe help us to get through this. There could be also discussion, and we should also maybe target new things, especially for the younger generations, how to bring up the hope. If you have some ideas and some thoughts about about looking it to the future? Thank you.
Well, thank you. These are both really interesting and important points. On the issue of ethnicity, the ethnic minorities, at least in this country, have had a different experience of the pandemic in certain respects, and it's very difficult to disentangle that from economic disadvantage. And of course, there are regional variations across England, which reflect the size of the ethnic minority populations. But I think we should be conscious of the potential mental health consequences of those differences. Mortality rates have been higher. The sense of sign up to public health measures has been lower. So vaccination rates are lower among ethnic minorities in this country than they are in the majority white population. So we have to recognize a different experience, a different sense of society, of social responsibility and protection. And that may well have consequences to people's mental health. I think on young people, there is a great deal of concern about young people in England, despite the ONS figures suggesting the suicide rate didn't initially go up, at least. And for me, it is partly the disruption to their lives during the pandemic, when education was so disrupted, when social contacts were disrupted. You saw some of the sense that people were losing contact with friends in one of my slides. But I also think that we have to remember that this is, at least in England and in some other rich countries, this is reflecting the pattern of suicide that existed before the pandemic. The pandemic has enhanced and magnified and made worse what was already happening for young people. Young people in this country were already feeling disillusioned and disenchanted, disconnected with some of the aims of society. Their concerns about their own lives, but about the values of wider society, were not being reflected in how they saw society developing, in the political priorities, in our social priorities, in the social conversation that happens about our futures. And we need to provide young people with a reassurance that their values will be listened to, that their voice matters, that their opportunities will be restored. And I must say, if I was a minister in the government, which I'm not, if I was a minister, I would be launching not just a recovery strategy, but a particular focus on young people, in which young people were in the lead. Because I think the potential for long-term disillusionment in young people, with all the mental health consequences that could come with that, is very real.
Thank you. Very, very important points, further points from here, and thank you also for Durkheim, by the way, which was a very good point regarding the anomia. But now I will be closing by a very, very brief conclusion. What we have heard today tells us that rather than having caused an increase in suicidality, it seems that the COVID may have actually caused the opposite, and due to some kind of perhaps social cohesion. However, it has become evident today that there are things that we should be very worried about related to COVID, and things I actually picked up were things like loneliness is important. We should be worried about mental health services, how they are doing, referral times, dropouts and referral times. We should be worried about young people, as we just heard from Louis, and actually also older people may be forgotten in the midst of all this. And altogether, it seems that the disparity and the risk of marginalization and people differing in their suffering may be a very important issue, both in the short and actually especially in the long term. So very important points, and we should be very aware about what is happening now and what will happen in the future during the COVID, and when the COVID will be over, because it sure will be over at some point.